Last week, something shifted. No headlines, no press conferences, no public outrage, just quiet language changes. Across multiple healthcare systems and payer contracts, the definition of medical necessity is being rewritten, not clinically, but financially. Not by bedside providers, not by specialists, but by committees, analysts, and algorithm backed policy teams. And here is what that actually means. Treatments that were once standard are now being labeled low value care or non essential frequency, excess utilization. And once that label is applied, the system moves in. Approvals get tighter. Denials increase, documentation requirements multiply, and reimbursement starts disappearing. There's no announcement, just friction. And here is the part no one ever says out loud. This is not cost control. This is care restriction, disguised as clinical refinement. You already feel it when you are on the floor. Dialysis patients being questioned for frequency. Chronic care patients forced into narrower treatment windows. And providers spending more time defending care than actually delivering it. And every denial comes with the same quiet implication. Prove they deserve it. Not, does the patient need it? But can you justify the cost of them receiving it? That shift right there, that's the line being crossed. Because once medical necessity becomes negotiable, care becomes conditional. This doesn't hit policymakers. This hits the congestive heart failure patient who decompensates because treatment timing got stretched. The dialysis patient who misses sessions and gets flagged as non-compliant instead of supported. The clinician forced to choose between doing what's right or doing what gets approved. And when those collide, the system does not absorb the damage. The patient does. The clinician carries it. Hospitalizations rise, complications increase, and mortality quietly follows. And the system calls it optimization. And here is how they have engineered it. They don't say no. They say things like, not indicated at this time. It requires further review. It does not meet updated criteria. So they delay, they burden, and they exhaust until either the provider stops pushing, the patient falls through, or the outcome worsens enough to justify higher cost intervention later. That is not healthcare. That is strategic attrition. You are being placed in a controlled conflict zone where advocacy equals resistance, efficiency equals compliance, and silence equals survival. You are expected to document more, defend more, produce more, all with less autonomy and more scrutiny. And if you do not play the game, you get labeled insufficient, non-compliant, or not aligned with system goals. That is not performance management. That is behavioral conditioning. So like always, let me strip this down to the truth. When financial structures redefine medical necessity, care is no longer dictated by need. It is dictated by tolerance for cost. And when that happens, people do not lose access overnight. They lose it slowly, quietly, systematically. There are no alarms, just outcomes. So, what do? You do not collapse under it. You sharpen. You document with precision, not compliance, but protection. You speak in facts, not emotion, but evidence. You recognize patterns, not isolated cases, but systemic shifts. And most importantly, you stop gaslighting yourself. You are not imagining this. The pressure is real. The shift is real. The consequences are already happening. So I am asking you, frontline to frontline, have you felt this change? Have you been forced to justify care that used to be automatic? Have you seen patients get pushed into criteria gaps? Have you felt the tension between what's right and what is allowed? Drop it. Say it out loud. Document it. Because this does not change in silence. And right now, that is exactly what the system is counting on. This is controlled care. And if no one calls it out, it becomes the new standard.